Imagine sitting at a restaurant, having a perfectly normal dinner. You take a bite of a dessert, and hidden in that bite is a single microscopic fragment of a peanut protein. And within like 3 minutes, your blood pressure completely crashes, the smooth muscles in your airways clamp shut, fluid starts leaking out of your blood vessels so fast that your tissues swell up, sealing off your throat. I mean, your body has basically initiated a catastrophic self-destruct sequence, and without an immediate injection of epinephrine, you could die.
Yeah, it is. It's one of the most terrifying cascades in all of human biology. And the profound irony here is that the peanut protein isn't a poison.
Right.
It's not venom. It is a completely harmless piece of a legume. The lethal threat isn't coming from the outside. The threat is, well, it's your own immune system.
And that is exactly what makes this topic so utterly fascinating and honestly a little unsettling. Usually when we talk about medicine, we're talking about defending the body against actual invaders, viruses, bacteria, parasites. It feels binary, good guys versus bad guys. But when we step into the world of hypersensitivity and allergies, we are entering a landscape of friendly fire.
Exactly. It's a fundamental miscalculation by an incredibly sophisticated defense network. A hypersensitivity reaction occurs when the immune system mounts an exaggerated, completely inappropriate attack against a benign stimulus. We call that stimulus an allergen or an antigen. So instead of ignoring a speck of pollen or, a bit of cat dander or a nickel coin, the body deploys its heaviest cellular artillery, and that causes massive collateral tissue damage.
And if you're listening to this thinking, well, I don't get hives, so this doesn't apply to me, the epidemiology paints a very different picture. In industrialized nations today, somewhere between 25 to 40% of the population experiences some form of hypersensitivity. I mean, 40% of us are walking around with immune systems that occasionally or constantly misread the room.
Which is exactly why we need to look under the hood. True medical literacy doesn't come from just memorizing a list of symptoms or knowing which over-the-counter pill to swallow. It comes from understanding the exact cellular choreography beneath those symptoms. Like, why does one specific immune cell release a specific chemical? How does that chemical physically alter the architecture of your blood vessels?
Welcome to our comprehensive, university-level audio masterclass on immunology. As your instructional designers and professors for this session, we are taking a deep dive into the 4 distinct types of hypersensitivity reactions. Immunologists categorize them simply as types 1, 2, 3, and 4. We're going to trace the exact mechanistic cascades of each one. We'll explore the immediate, explosive reactions, dive into the genetics of why certain people are targeted, look at what happens when the immune system attacks our own cells, examine the damage caused by free-floating immunological debris, and finally, look at a delayed cellular assassination protocol.
It's a journey through the microscopic battlefields of our own tissues. And this deep dive will follow a strict 5-module progression to ensure total coverage.
Okay, let's unpack this. We're jumping right into the most famous, most rapid reaction of them all. Module 1. Type hypersensitivity. This is the immediate kind, the classic allergy. But there's a massive misconception about how this actually starts. Let's say I've never eaten a strawberry in my life. I eat one for the very first time. Wait, so the first time I'm exposed to an allergen, I don't actually get the clinical allergic reaction. What is happening behind the scenes?
Right. The shadow process is everything here. You absolutely do not react clinically on your first exposure. Instead, you undergo a silent behind-the-scenes priming process, which we call the sensitization phase. When you eat that first strawberry, the proteins from it enter your digestive mucosa. And waiting there are specialized scout cells of the immune system, primarily antigen-presenting cells, or APCs. Their entire job is just to sample the environment.
So an APC bumps into the strawberry protein. Normally, you should just sample it, realize it's food, and, stand down.
Exactly. But in someone who is prone to allergies, the system misfires right from step 1. The APC ingests the harmless allergen, chemically chops it up inside its cellular machinery, and then it takes a tiny peptide fragment of that protein and displays it on its outer surface. It is essentially holding up a microscopic mugshot of the strawberry.
Okay, and it then takes that mugshot and travels to the local police station, like the nearest lymph node, to show the detectives.
Yeah, that's a good way to put it. The detectives in this case are a very specific lineage of white blood cells known as T helper 2 cells, or Th2 cells. The APC presents the strawberry peptide to the Th2 cell. The Th2 cell inspects it and makes a fateful decision. It flags this harmless food peptide as a high-level biological threat.
I want to pause on that interaction because this isn't just a physical bumping of cells, they communicate chemically. If the Th2 cell decides this is a threat, how does it sound the alarm?
Through an incredibly potent class of chemical messengers called cytokines. The moment the Th2 cell activates, it begins secreting a specific, highly orchestrated cocktail of interleukins into the surrounding lymph node tissue. The three most critical ones in this early phase are IL-4, IL-10, and IL-13.
And those chemicals are looking for a target. They wash over the nearby B cells, right? The factories of the immune system.
Yes, B cells are the cells responsible for manufacturing antibodies. Now, in a default state, a newly activated B cell usually produces a generalized antibody called IgM. But when that B cell is suddenly bathed in the Th2 cytokines, specifically IL-4 and IL-13, it undergoes a radical genetic restructuring. The B cell actually splices its own DNA to change the type of antibody it is producing. We call this mechanism class switching.
Oh, wow. So the factory physically retools its assembly line based on the chemical orders it just received.
Exactly. And the new product rolling off the assembly line is immunoglobulin E, or IgE. The B cell transforms into a specialized plasma cell and starts pumping out massive amounts of IgE antibodies. And because the original alarm was triggered by the strawberry protein, every single one of these billions of IgE antibodies is specifically tailored, physically shaped, to recognize only that exact strawberry peptide.
But, I mean, producing the weapons doesn't cause the allergy symptom. The weapons have to be deployed. Where do these IgE antibodies go once they leave the lymph node?
They disseminate throughout the entire body, and they're hunting for very specific docking stations. These docking stations are called high-affinity Fc epsilon Ri receptors. The notation is F-core-II.
That is quite the alphabet soup. F-core-I. Why are these specific receptors so dangerous?
Because of where they are located. You only find these high-affinity receptors densely packed on the surface of two highly volatile types of immune cells. The first are mast cells. Mast cells do not circulate. They are embedded deep in your connective tissues, standing guard around your blood vessels beneath your skin, and lining your respiratory and gastrointestinal tracts. The second type are basophils, which patrol the bloodstream itself.
So you have stationary guards in the tissue and mobile guards in the blood. And they're just covered in these receptors.
Right. The newly minted IgE molecules find these cells and anchor themselves by their tail ends, the Fc portion, directly into the Fc receptors. They lock in tightly. They sit there on the surface of the mast cell, facing outward, functioning like tiny satellite dishes waiting to intercept a signal.
Okay, so the traps are set. But to the patient, nothing happened. They ate a strawberry, digested it, and went about their week. No hives, no swelling. But they are now officially sensitized. The loaded gun is pointed. So what happens a month later when they eat a strawberry for the second time? Let's talk about the re-exposure phase.
The allergen enters the body, but this time it doesn't need to find an APC. The allergen circulates and physically encounters those mast cells that are already bristling with IgE. The strawberry protein binds to the IgE antibodies. However, and this is key, simply bumping into a single IgE molecule does absolutely nothing. The mast cell remains dormant.
That makes sense from an evolutionary standpoint.
Sure.
You wouldn't want a system this destructive to go off just because of random molecular noise. It needs a failsafe.
Exactly. To picture this failsafe, think of a nuclear submarine launch protocol. To launch the missiles, you cannot have one single captain accidentally bump a launch button on the control panel. The system requires two separate keys, inserted into two different locks, turned simultaneously to authorize the launch.
Oh, I see. So on the surface of the mast cell, the high-affinity F-core-I receptors are the control console. The IgE molecules are the keys. And the allergen is the captain turning them both at the exact same time. The allergen must physically bridge, or cross-link, two adjacent IgE molecules.
You've got it. That physical cross-linking is the ultimate mechanical trigger. When one allergen molecule binds to two IgE antibodies at the same time, it physically pulls the two underlying F-core-I receptors together on the cell membrane. This microscopic clustering sends a shock wave into the interior of the mast cell, immediately opening calcium channels.
Calcium rushes from the outside of the cell into the interior.
A massive intracellular calcium flood. That calcium spike is the final authorization code. It causes the internal cytoskeleton of the mast cell to forcefully contract, pushing thousands of storage vesicles to the cell membrane where they fuse and dump their contents into the surrounding tissue. This is the degranulation sequence.
It just vomits biological bombs into the local neighborhood. And this triggers what immunologists call the biphasic reaction, meaning it happens in two distinct waves. Let's trace the immediate phase first, which kicks in within like 5 to 30 minutes of that calcium influx.
The immediate phase is entirely driven by preformed mediators. The mast cell didn't have to build these on the spot. It had them synthesized, packed into those granules, sitting there for months just waiting for the signal. The most famous of these preformed mediators is histamine.
Right. We all know histamine from allergy commercials, but what is it actually doing to the tissue when it hits the extracellular space?
Histamine binds to H1 receptors on the endothelial cells that line your local blood vessels. It forces those cells to physically contract and pull apart from one another. The blood vessel undergoes massive vasodilation. It opens up and becomes highly permeable or leaky. Blood plasma rushes out of the vessel and into the tissue.
Which we visually see as edema, swelling, like a hive on the skin or swelling in the nasal passages.
Right. But if histamine hits the smooth muscle wrapped around your bronchial tubes in the lungs, it does the exact opposite of relaxing them. It causes them to violently contract, tightening the airways.
So you have vessels leaking fluid and airways clamping shut. But histamine is just one weapon in the granule. What else is in there?
You also have heparin, which is a powerful anticoagulant. It stops blood from clotting in the localized area, ensuring that more fluid and immune cells can rush in without being blocked. And then you have a suite of highly destructive enzymes called proteases.
Proteases are designed to literally chew up other proteins.
Specifically, the mast cell releases tryptase, chymus, carboxypeptidase, and caspin G. When these enzymes hit the tissue, they immediately begin degrading the local extracellular matrix, the structural scaffolding that holds your cells together. They cause blunt physical tissue damage, which further activates other inflammatory pathways in the surrounding cells.
All of this chaos happens in minutes. The patient experiences the sudden hives, the sudden wheezing. They take an antihistamine or use an EpiPen, and the symptoms start to subside. They think they're in the clear. But 4, 8, or even 12 hours later, long after the allergen has been cleared from their system, they suddenly have a massive resurgence of symptoms. Why?
Because of the late phase. When that initial calcium influx hit the mast cell, it didn't just cause the preformed granules to dump, it also sent a signal deep into the nucleus of the mast cell and to its lipid membranes, ordering the cell to start manufacturing brand new mediators from scratch.
So the initial attack was using stockpiled weapons, but simultaneously it turned on the wartime factories. And it takes hours for those new weapons to be built, hence the delay. What are they building in the late phase?
First, they build lipid mediators. The mast cell uses an enzyme to rip apart its own cellular membrane, pulling out a molecule called arachidonic acid, and converting it into highly potent inflammatory lipids. Specifically, it produces prostaglandins, primarily PGD2, and leukotrienes, particularly LTC4. It also generates a molecule called sphingosine 1-phosphate, or S1P.
How do these compare to histamine? Are they stronger?
Exponentially stronger. LTC4, for instance, is orders of magnitude more potent than histamine at causing smooth muscle contraction. While histamine might cause a brief wheeze, the leukotrienes are responsible for the severe, long-lasting airway constriction you see in a chronic asthma attack.
But they don't just build lipids. The mast cell also starts churning out a massive chemical soup of newly synthesized cytokines and chemokines.
Yeah, this is where the reaction transitions from a localized event into a major cellular recruitment drive. The mast cell begins secreting newly synthesized IL-5. Think of IL-5 as a specific homing beacon that travels through the blood, grabs resting eosinophils, and summons them to the tissue. It releases IL-8, which does the same thing for neutrophils.
It's drafting an army.
Exactly. It also releases IL-6, IL-10, IL-13, and IL-16. It pumps out tumor necrosis factor alpha, or TNF-alpha, which radically amplifies widespread inflammation. It secretes granulocyte macrophage colony stimulating factor, or GM-CSF, along with chemokines like MCP1 and MIP1A.
Wow. If I can distill that alphabet soup, this entire secondary wave of chemicals has one primary job: massive cell recruitment. They call in waves of heavy infantry, neutrophils, more macrophages, the highly destructive eosinophils. And when those cells arrive, they sustain the inflammation for hours, sometimes days, constantly damaging the tissue, even though the original strawberry protein is long gone.
The sheer scale of the amplification is staggering. A single, localized cross-linking event cascades into a localized war zone.
Now, before we summarize this module, I want to explore a fascinating loophole. In biology, there is always an exception to the rule. We just spent 20 minutes establishing that type hypersensitivity requires a very strict sequence: sensitization, APCs, Th2 cells, IgE production, and then cross-linking. But there's a scenario where a patient can experience this exact same explosive mast cell degranulation on their very first exposure, bypassing IgE entirely.
Ah, yes. Those are termed anaphylactoid reactions. If you look at a patient experiencing one, clinically, they look identical to someone in anaphylactic shock. The hives, the swelling, the blood pressure drop. But mechanistically, the reaction is completely IgE independent. Certain chemical or physical triggers have the ability to directly assault the mast cell and force it to degranulate, no sensitization required.
What could possibly bypass the lock and key system?
A classic clinical example is the iodine contrast dye used in medical imaging, like CT scans. The dense chemical structure of the dye can physically interact with the mast cell membrane or indirectly activate complement proteins in the blood that bind to the mast cell, directly forcing those calcium channels to open.
So it essentially shorts out the console, causing a launch without the keys.
Opiates, such as codeine or morphine, are notorious for this as well. They can bind directly to specific receptors on the mast cell surface that trigger histamine release. Even physical extremes, like a sudden plunge into freezing water, intense radiant heat, or severe direct sunlight, can apply enough physical stress to the mast cell's lipid bilayer that it destabilizes, causing calcium influx and degranulation. The mast cell dumps its histamine, tryptase, and eventually synthesizes the lipid mediators, causing the exact same biphasic reaction, but completely cutting the Th2 cells and the B cells out of the loop.
That is wild. The system is so volatile that sometimes just physical temperature changes can set it off. Okay, let's briefly synthesize Module 1. We covered the sensitization phase, where APCs present to Th2 cells, leading to IL-4 and IL-13, forcing B cells to make IgE. Then the cross-linking of that IgE on FcRI receptors causes explosive mast cell degranulation, with an immediate phase of preformed granules like histamine and a late phase of newly synthesized cytokines and lipids. And while we now know how it happens, Module 2 will reveal why certain people are targeted by their own genes and environment and how we clinically manipulate these pathways.
Right. Module 2, Type I genetics, environment, and clinical applications.
So we now know the machinery. But why does this machinery misfire in some people and not others? Why does my immune system produce IgE against a peanut, while the person sitting next to me eats peanuts all day long with no issue?
To answer that, we have to look at the architectural blueprints. Genetic susceptibility. It is not just a run of bad luck. A significant portion of this is hardwired into your DNA. Individuals who are prone to these reactions are clinically termed atopic. Atopic individuals have a fundamental genetic bias to mount Th2 heavy immune responses instead of the standard Th1 responses.
When immunologists look at the human genome, where are they finding the loaded guns for this atopy? What chromosomes are involved?
Two major chromosomes repeatedly emerge in the data. The first is chromosome 11. This chromosome is critical because it houses the specific gene that codes for the beta chain of the high-affinity FcRI receptor.
The receptor on the mast cell, the control console.
Right. If a patient inherits a mutation or a specific polymorphism in this region of chromosome 11, their mast cells might physically express a much higher density of these receptors on their surface. Or the receptors themselves might be structurally hyperresponsive when RGE docks. The threshold for activation is genetically lowered.
Okay, so chromosome 11 builds a more sensitive trigger. What about the other one?
Chromosome 5. This one is a massive evolutionary hotspot for atopy. Chromosome 5 houses the genetic codes for an entire cluster of cytokines tightly packed together: IL-3, IL-4, IL-5, IL-9, IL-13, and GM-CSF.
Those are the exact cytokines we just outlined. IL-4 and IL-13 are the ones that force the B cells to class switch to IgE. IL-5 is the homing beacon that guarantees the survival and recruitment of eosinophils. IL-3 and GM-CSF control the proliferation of the mast cells themselves.
It's a localized genetic factory for allergy. Because these genes are clustered so closely together on chromosome 5, they share regulatory elements. If you inherit regulatory regions that naturally overexpress this entire cluster, your baseline immune environment is heavily, constantly tilted toward allergic cascades.
It's not just the broad cascades either. I've read that genetics can dictate exactly what you're allergic to, based on how your cells present the antigen in the very first step.
Absolutely. This correlates with the major histocompatibility complex, which in humans is called the HLA system. The HLA molecules are the physical hands that the antigen-presenting cell uses to display the peptide mugshot to the Th2 cell. There are thousands of genetic variations of these hands. For instance, there is a specific genetic haplotype called HLA-B115 or 1.
And what does HLA-B11501 do?
The clinical data shows that individuals who inherit that specific allele are mathematically far more likely to produce IgE specifically against ragweed pollen. The physical shape of that specific HLA molecule happens to bind ragweed peptides perfectly, presenting them in a highly inflammatory way to the Th2 cells.
So the loaded gun is genetic. But genetics alone cannot explain everything. Human DNA hasn't drastically changed in the last century, yet we have seen a massive, unprecedented spike in allergies in the last few decades. The trigger has to be environmental. What is in our modern environment, or what is missing from it, that is pulling this genetic trigger?
This conundrum gave rise to one of the most famous epidemiological theories in modern medicine, the hygiene hypothesis, originally proposed in 1989. A researcher was studying the prevalence of hay fever in large families and noticed a highly consistent yet counterintuitive trend. The firstborn children were consistently the most allergic, while the youngest siblings, the fourth or fifth children, were the least allergic.
If you think about infectious disease, you'd assume the opposite. The youngest kids are constantly exposed to whatever the older kids drag home from school, so they should be sicker.
But that constant exposure is the exact protective mechanism. The original hypothesis posited that firstborn children are usually raised in highly sanitized, carefully controlled environments. By the time the fourth child arrives, the parents are exhausted. The pacifier falls on the floor, they wipe it on their shirt and hand it back. The younger children are exposed to far more dirt, environmental microbes, older siblings' colds, and animals early in life.
I understand the correlation. But what is the cellular mechanism? How does playing in the dirt prevent a child from developing an allergy to pollen?
You have to ask yourself, why does the human body even have the IgE system? It didn't evolve to give us asthma or make us allergic to cats. The IgE and mast cell system evolved over millions of years to fight large, multicellular parasites like intestinal helminth worms. If a child is raised in a natural, less industrialized setting, exposed to diverse environmental microbes and mild parasitic infections, their immune system is kept incredibly busy.
It's fighting actual wars.
Right. It produces anti-parasite IgE. Those IgE molecules bind to the mast cells occupying the Hepsarii receptors. The system is saturated, functioning exactly as evolution intended, but in our hyper-sterile, sanitized modern environments, the immune system has no parasites to fight. The Th2 response is essentially bored. It misdirects its energy, producing IgE against completely harmless proteins like pollen or peanuts, simply because the receptors are empty and the system is idling.
The immunological equivalent of idle hands being the devil's workshop. But modern immunology has updated this theory, haven't they? It's not just about occupying the receptors, it's about the active suppression of the immune system by peacekeepers.
Yes, the modern corollary is known as the counter-regulatory hypothesis, and it centers on a specific cell type, regulatory T cells, or TREGs. TREGs are the ultimate peacekeepers of the immune system. When the immune system is continuously stimulated early in life by diverse, harmless environmental microbes, often referred to as old friends, it doesn't just make active fighting cells, it trains a robust, highly active population of TREGs.
And how do TREGs keep the peace?
They secrete potent suppressive cytokines, most notably IL-10 and TGF-beta, which stands for transforming growth factor beta.
What do those two chemicals do to the allergic cascade?
IL-10 and TGF-beta are essentially the brakes of the immune system. They actively suppress hyperactive Th1 and Th2 responses. They tell the APCs to calm down. They prevent B cells from class switching to IgE. In our modern sanitized environments with our antibacterial soaps, our heavily processed diets, and our frequent use of antibiotics, we lack that early diverse microbial stimulation. Therefore, we fail to develop a robust population of TREGs.
The absence of early microbial dirt leads to a sheer absence of peacekeepers later in life.
Without TREGs constantly secreting IL-10 and TGF-beta to apply the brakes, the genetic Th2 responses flourish completely unchecked, leading to a lifelong cascade of flourishing allergies.
That is a profound way to look at how our modern world is reshaping our biology. Let's pivot from the theoretical to the clinical. Let's say a patient walks into a clinic with a suspected allergy. How do doctors clinically prove which specific mechanism is misfiring?
The gold standard for decades has been the localized skin prick test. We take a tiny, purified liquid extract of a specific allergen, say cat dander, and prick it barely into the epidermis of the patient's forearm. What we are doing is intentionally trying to trigger a highly localized microscopic type I reaction.
You're intentionally introducing the captain to see if the keys are in the console.
Precisely. We wait 15 to 20 minutes. If the patient has cat dander-specific IgE laid on the mast cells in their skin, the allergen will cross-link them. The calcium channels open, the mast cell degranulates, and histamine is released locally into that specific millimeter of tissue.
And visually, the doctor is looking for the wheel and flare reaction.
The wheel is the raised, pale, fluid-filled bump right at the prick site. That is caused by the histamine making the local blood vessel leaky, causing localized edema. The flare is the wide red ring spreading around it, caused by the histamine-induced vasodilation bringing excess blood to the area. We literally take a ruler and measure the physical diameter of that wheel to gauge the severity of the sensitization.
But sometimes skin tests aren't safe. If a patient has a history of life-threatening anaphylaxis to a peanut, you don't want to intentionally prick them with peanut protein, even in a controlled setting.
In those high-risk cases, we use blood tests. We draw serum and run highly sensitive assays like ARS or specific ELISA tests. These tests can physically quantify the exact titer or concentration of specific IgE antibodies circulating in the blood.
Does an allergic person just have a massive, overwhelming amount of total IgE in their blood compared to other antibodies?
Interestingly, no. It is vital to note that even in the most severely allergic, highly atopic patient experiencing anaphylaxis, the absolute concentration of IgE in their serum will never numerically exceed their overall baseline levels of IgG or IgM. IgE is incredibly potent because of its binding affinity to mast cells, but it remains a trace immunoglobulin in the overall blood volume compared to the others.
Okay, so we've mapped the genetics, the environment, and the diagnostics. How do we treat it? Let's break down the pharmacology using the mechanisms we just learned. Let's start with the only treatment that can actually cure an allergy: desensitization, commonly known as allergy shots.
Desensitization is a brilliant form of immunological reprogramming. We inject the patient with carefully escalating subclinical microdoses of the allergen week after week over months or even years. By introducing the antigen in this very specific, low-grade, persistent manner, we aren't trying to trigger mast cells. We are trying to shift the patient's entire baseline immune profile.
You're trying to talk the immune system out of the Th2 response.
Exactly. The persistent low-dose exposure slowly trains the immune system to abandon the Th2, IgE heavy pathway, and pushes it toward a standard Th1 response. Furthermore, it stimulates those TREGs we discussed earlier to start producing IL-10.
And by shifting to Th1 and increasing IL-10, what physically happens to the antibodies?
The B cells receive new orders. They stop class switching to IgE, and instead they start producing large amounts of IgG antibodies against the allergen. These newly formed IgG antibodies act as blocking antibodies.
Blocking antibodies, how do they work mechanically?
Now, when the patient encounters the allergen in the real world, they get stung by a bee or eat a peanut, these highly abundant IgG molecules swarm and bind to the allergen while it is still circulating in the bloodstream, neutralizing it before it can ever reach the tissue and find the IgE on the mast cells.
That is brilliant. It intercepts the signal in transit. No cross-linking, no degranulation. But desensitization takes years. What if you were in the middle of an acute reaction? You reach for antihistamines or corticosteroids.
Mechanistically, antihistamines are simple competitive receptor antagonists. They flood the bloodstream and bind to the H1 receptors on your blood vessels and smooth muscles, blocking the histamine from docking. The mast cell might still be degranulating, dumping massive amounts of histamine, but the histamine has nowhere to bind. The vessels don't leak, so you don't get the swelling and itching.
But antihistamines only block the immediate phase. What about the late phase, the leukotrienes and the cytokines?
That is where corticosteroids come in. Corticosteroids are heavy systemic artillery. They are lipid-soluble, meaning they pass right through the cell membrane, enter the cytoplasm, and travel directly into the nucleus of the mast cells and other inflammatory cells. Once inside the nucleus, they bind to the DNA and actively shut down the transcription of those newly synthesized cytokines and lipid mediators. They physically stop the factory from producing IL-5, LTC4, TNF-alpha, and all the rest.
It cuts the supply lines for the late phase. There's one more drug class I want to cover because it sounds like science fiction. A biologic drug called omalizumab.
Omalizumab is a marvel of modern bioengineering. It is a monoclonal antibody. Basically, it is an artificial, laboratory-designed antibody that acts as an anti-IgE. When injected into a patient, it specifically targets and binds to the free-floating IgE molecules in the patient's blood.
Wait, antibodies have two ends, the tips that grab the target and the tail end, the Fc portion. Where exactly does omalizumab bind on the IgE?
That is the genius of its design. It specifically binds to the Fc portion, the tail end of the patient's IgE.
But if it binds the tail end, isn't that the exact physical structure the IgE uses to dock onto the mast cell's high-affinity receptor?
That intercept is the whole mechanism. By binding to the Fc portion, omalizumab physically caps the tail of the IgE. Because the tail is covered, that IgE molecule can no longer physically fit into the high-affinity FTRI receptors on the mast cells or basophils. It neutralizes the keys before they can ever be inserted into the submarine console. Over a few weeks, the mast cells run out of docked IgE, and the patient's allergic reactivity plummets.
It is stunning how precise we can be when we understand the mechanism. Let's do a bit of clinical anchoring to connect these deep cellular mechanisms to the actual diseases people suffer from every day.
The clinical disease depends entirely on where the mast cell degranulation occurs. If an inhaled allergen cross-links IgE on the mast cells located in your upper airway, the nasal epithelium, you get allergic rhinitis or hay fever. The localized histamine causes vasodilation and edema, which physically obstructs the nasal passages. The released cytokines summon eosinophils, which damage the mucosa and cause that profuse, clear, watery discharge.
But if you inhale the allergen deeper down into the lower airways, the clinical picture changes.
Drastically. That results in allergic bronchial asthma. Down in the lower airways, the lipid mediators take over. The newly synthesized leukotrienes, specifically LTC4, cause severe, prolonged bronchoconstriction. The smooth muscles wrapped around the bronchioles clamp down tightly. Simultaneously, the late-phase cytokines signal the local goblet cells to overproduce thick, viscous mucus, which physically plugs the narrowed airways. It is a dual mechanism of suffocation.
And if the allergen bypasses the airways entirely and enters the systemic bloodstream, say from a bee sting injecting venom or a peanut protein absorbing through the gut, you get the ultimate nightmare, systemic anaphylaxis.
Massive system-wide degranulation of both tissue mast cells and circulating basophils. The sudden systemic release of histamine causes vasodilation everywhere at once. The blood vessels expand so much that the total vascular volume increases drastically, causing a catastrophic drop in blood pressure. This is anaphylactic shock. At the same time, fluid leaks into tissues systemically. If that fluid leaks into the larynx, the glottis swells shut, physically preventing air from reaching the lungs. It is rapidly fatal without epinephrine, which acts to immediately constrict the blood vessels and relax the airway smooth muscle, temporarily reversing the histamine effects until steroids can kick in.
Before we close the book on type I want to use comparative reasoning to clear up a massive public confusion regarding food. People use the words allergy and intolerance interchangeably, but mechanistically, they're universally different. Let's compare a true milk allergy side by side with milk intolerance.
This is a vital clinical distinction. A true milk allergy is a type I hypersensitivity. The body's APCs processed a specific milk protein, usually casein or whey, presented it to a Th2 cell, and the B cells produced casein-specific IgE. When that person drinks milk, the casein protein cross-links the IgE, and mast cells in the gastrointestinal tract degranulate. The massive histamine and leukotriene release causes severe, violent vomiting, diarrhea, hives, or even systemic anaphylaxis. It is an aggressive immune system attack.
And milk intolerance. Let's look at lactose intolerance.
Lactose intolerance has absolutely nothing to do with the immune system. There are no APCs involved, no Th2 cells, no IgE, and no mast cells. It is purely a mechanical digestive deficiency. The person's intestinal lining simply does not produce enough of an enzyme called lactase, which is required to break down lactose, the complex sugar found in milk.
So the sugar just sits there.
It passes undigested into the large intestine where the normal gut bacteria feast on it. As the bacteria ferment the sugar, they produce massive amounts of gas. This causes bloating, cramping, and osmotic diarrhea. It is highly unpleasant, but it is completely non-immunological and will never cause anaphylaxis.
Let's apply that exact same comparative logic to wheat. A true wheat allergy is, again, an IgE cross-linking reaction against wheat proteins, causing hives or respiratory distress. But what about celiac disease? People often call it a gluten allergy.
Calling it an allergy is mechanistically incorrect. Celiac disease is triggered by the ingestion of wheat, specifically the gluten protein, but it is not a type I IgE reaction. It is a severe autoimmune disorder. When a celiac patient eats gluten, their immune system reacts, but it does so via a non-IgE, heavily T-cell mediated response. The T cells become activated and mount a highly localized inflammatory attack against the patient's own intestinal lining, physically destroying and flattening the microscopic villi that absorb nutrients. The trigger is the same as a wheat allergy, but the immunological machinery carrying out the destruction is entirely different.
Okay, that was a huge module. Let's synthesize module 2. We covered genetic susceptibilities on chromosome 11 and chromosome 5 and the HLA-B11501 allele. We unpacked the hygiene hypothesis versus the counterregulatory hypothesis with TREGs and IL-10. We went through skin pricks, ELISAs, desensitization shifting Th2 to Th1, and drugs like omalizumab. And that profound difference in machinery with celiac is the perfect bridge. We are going to move away from IgE entirely. We are moving away from immediate allergies, stepping into the realm of mistaken identity on the surface of our own cells. Module 3, Type 2 Hypersensitivity.
Also known as cytotoxic hypersensitivity. We are shifting gears entirely regarding the weapons the body uses. In Type 1, the star of the show was IgE. In Type 2, the immune system shifts to using its most abundant standard-issue weapons, IgG and IgM antibodies.
And crucially, the target is no longer floating around freely.
Correct. The defining characteristic of type 2 is that the target, the antigen, is bound directly to the surface of the patient's own cells. The immune system is essentially painting a molecular bullseye directly onto the lipid membrane of your own red blood cells or your platelets.
Why would the body suddenly decide its own red blood cell is an enemy?
Sometimes it's an intrinsic error, a true autoimmune failure, where the body stops recognizing a normal structural protein as self. But very often, it's driven by an extrinsic factor. A classic example involves certain medications, drugs like the antibiotic penicillin, the antiarrhythmic drug quinidine, or the blood pressure medication methyldopa.
How do those drugs trick the immune system into attacking a red blood cell?
By physically altering the cell's appearance. When a patient takes penicillin, those drug molecules circulate in the blood. In some patients, the drug molecules physically adhere and bind tightly to the surface membrane of their red blood cells or platelets.
They stick to the outside of the cell like barnacles on a ship's hull.
Exactly. And when an APC comes along and inspects that red blood cell, it doesn't just see the normal self-proteins. It sees this weird, foreign penicillin molecule stuck to the surface. To the immune system, the cell now looks infected or altered. It mounts a response. B cells are instructed to produce IgG or IgM antibodies that are specifically designed to bind directly to those drug molecules stuck on the cell surface. The red blood cell is now heavily coated in antibodies.
The bullseye is painted, but antibodies don't actually kill cells on their own, do they? They're just markers. So what fires the arrow? What is the actual mechanism of destruction?
There are two main pathways of cellular destruction in type 2 hypersensitivity. The first is a biochemical waterfall known as complement activation, leading to the formation of the membrane attack complex, or MAC.
Let's trace that cascade step by step. How does a marker turn into a MAC?
It starts with the shape of the antibody. When an IgG or IgM molecule floating in the blood binds to its target on the surface of the cell, the tail end of the antibody, the Fc portion, undergoes a physical conformational change. It changes shape. This new shape acts as a docking station for a protein constantly circulating in your blood called C1q.
C1q is the first domino in the complement system.
Yes. When C1q binds to the antibody, it activates, and it acts like a cleaver, chopping and activating the next complement proteins in line, primarily C2 and C4. This triggers a sequential, cascading waterfall of complement proteins, cleaving and activating each other on the surface of the cell. Ultimately, this cascade recruits the final proteins, which assemble themselves into a rigid, microscopic ring structure. This is the membrane attack complex.
What does this ring actually do to the cell?
It physically drills a lytic pore, a literal unsealable hole, straight through the lipid membrane of the red blood cell.
It punches a hole in the hull of the ship.
And once the hull is breached, physics takes over. Because the inside of the red blood cell is packed with proteins and ions, it has a high osmotic pressure. Water from the blood plasma rushes into the cell through the newly drilled pore, trying to balance the concentration. The cell rapidly swells, the membrane stretches beyond its limits, and the cell bursts open. It is destroyed by osmotic lysis right there in the bloodstream.
That is a brutal mechanism. The drug sticks to the cell, the antibody sticks to the drug, the complement cascade builds a drill, and the cell explodes. That's pathway 1. What is the second pathway of destruction?
Opsonization and phagocytosis. The word opsonization comes from a Greek word meaning to prepare for eating. In this pathway, the red blood cell is coated in IgG antibodies and early complement proteins, acting like a chemical sauce.
The bullseye is now a seasoning.
As this coated red blood cell travels through the circulatory system, it eventually passes through the spleen. The spleen is a highly vascular organ packed with millions of highly aggressive macrophages. These macrophages have specific receptors on their surface that perfectly recognize the IgG sauce.
They grab the passing cell.
They grab it, engulf it entirely through the process of phagocytosis, and trap it inside a cellular stomach called a phagolysosome. There, they douse the red blood cell with concentrated acid and destructive enzymes, digesting it alive.
So depending on the exact cascade, the red blood cell is either drilled full of holes and explodes in the bloodstream, or it is eaten alive by macrophages in the spleen. Clinically, this leads to profound shortages of these cells. If the target is red blood cells, the patient develops hemolytic anemia. If the target is platelets, they develop thrombocytopenia, leading to severe bleeding disorders.
Both are direct results of the type 2 cytotoxic mechanism.
Here's where it gets really interesting. How does this explain what happens in certain pregnancies? Let's talk about hemolytic disease of the newborn.
Also known medically as erythroblastosis fetalis, this condition revolves around the Rh factor. The Rh factor is simply a standard protein antigen naturally found on the surface of red blood cells in most of the population. If you possess this protein, your blood type is Rh positive. If your genetics lack this protein, you are Rh negative.
So let's set up the dangerous scenario. Imagine a mother who has Rh-negative blood. Her immune system has never seen the Rh protein. To her, it would look like a foreign invader. But the father is Rh positive, and the fetus inherits the father's gene. The Rh-negative mother is now carrying an Rh-positive fetus.
Under normal circumstances, during the 9 months of the first pregnancy, everything is usually perfectly fine. The maternal blood supply and the fetal blood supply are kept strictly separate by the placental barrier. The mother's immune system remains completely unaware that the fetus has a foreign protein on its blood cells.
But birth is a physically traumatic event.
Exactly. During the physical trauma of the first delivery, as the placenta detaches and shears away from the uterine wall, the barrier breaks. A significant amount of fetal Rh-positive red blood cells spills directly into the mother's Rh-negative bloodstream.
And the mother's APCs finally see the Rh protein.
The mother's immune system detects these fetal cells and reacts exactly as it would to a bacterial infection. The APCs process the Rh antigen, present it to T cells, which activate B cells, which begin synthesizing highly specific anti-Rh IgG antibodies.
But this takes time. By the time she manufactures these antibodies, the first baby has already been born.
The first baby is safe. But the mother is now fundamentally altered. She is sensitized. She now possesses long-lived memory B cells circulating in her blood, silently waiting, ready to rapidly produce massive amounts of anti-Rh IgG at a moment's notice.
Now we fast forward a few years. She gets pregnant with a second Rh-positive fetus.
This is where the type 2 mechanism becomes devastating. During the second pregnancy, microscopic amounts of fetal Rh antigens can cross the placenta, or the mother's memory B cells simply detect the trace presence. The memory B cells reactivate, rapidly producing massive titers of anti-Rh IgG antibodies. And here is the critical defining biological fact of all the antibody classes. IgM, IgA, IgE, IgG is the only class of antibody that is physically small enough and possesses the correct transport receptors to easily cross the placenta from the mother into the fetus.
Oh, wow. So the maternal weapons cross the barrier.
The mother's anti-Rh IgG antibodies cross the placenta, enter the fetal bloodstream, and bind directly to the surface of the fetal red blood cells. The bullseye is painted on the fetus's own cells.
And because it's a type 2 reaction, the fetus's own complement system and fetal splenic macrophages recognize the mother's IgG, and they begin destroying the fetus's own red blood cells.
The fetal immune system destroys its own blood supply via amaxillitic pores and opsonization. The fetus becomes severely, progressively anemic in utero. In severe cases, the fetal heart has to pump so hard to deliver oxygen with so few red blood cells that it leads to profound heart failure and death before birth.
It is a profound immunological tragedy, entirely driven by IgG binding to a fixed cell surface antigen. But modern medicine actually has a brilliant intercept for this, don't they?
It is one of the great triumphs of preventive immunology. We administer an injection of synthetic, laboratory-made anti-Rh antibodies, a drug called Rojam, to the mother during the third trimester, and crucially, within 72 hours after the delivery of the first baby.
Wait, if the problem is anti-Rh antibodies, why are we injecting more of them into the mother?
Because these are synthetic, passive antibodies. When the fetal Rh-positive cells spill into the mother's blood during birth, the synthetic Rojam antibodies immediately hunt them down, bind to them, and facilitate their clearance from the mother's bloodstream before the mother's own APCs and B cells can ever see them. We completely hide the fetal cells from the mother's immune system. We intercept the signal before the memory B cells can ever form.
You essentially sweep the floor clean before the detectives arrive. No sensitization, no memory cells, and the second pregnancy is completely safe. That is incredible. Okay, synthesizing Module 3 quickly. We saw IgG and IgM attacking cell-bound antigens, leading to destruction via amylolytic pores and splenic macrophages. But what happens if the antigen isn't glued to anything? What if it's just floating free in the blood, creating a dangerous clumping debris field?
That architectural difference defines Module 4, Type 3 hypersensitivity, the immune complex disease.
Let's do a direct comparative segment right here to make this crystal clear. Type 2 versus Type 3.
In Type 2, the antibody attacks a fixed cell-bound antigen. The battlefield is strictly limited to the surface of that specific targeted cell. In Type 3, the antibodies, again, primarily IgG, are binding to soluble, free-floating antigens directly in the blood plasma or in the tissue fluids.
They're trying to grab onto the antigen while it's swimming by in the current.
Exactly. And because antibodies are Y-shaped with two binding sites and antigens often have multiple binding sites, they start cross-linking each other. When multiple IgG antibodies bind to multiple soluble antigens, they form a large three-dimensional lattice structure. This microscopic clump is called an immune complex. Now, to be entirely clear, forming immune complexes is a normal, highly effective, healthy part of fighting infections. Your body does this all the time to neutralize circulating viruses or bacterial toxins.
So how does a healthy routine process become a Type 3 hypersensitivity cascade? How do these floating clumps cause tissue damage?
It all comes down to a precarious balance of production versus clearance. Normally, these heavy Ig antigen complexes are kept safely soluble in the blood by specific complement proteins, primarily C2 and C4. These complement proteins bind to the complexes and act like a chemical escort. They keep the complexes dissolved in the fluid and guide them to the liver and spleen, where macrophages safely clear them away without any collateral damage.
Okay, to visualize how this goes wrong, imagine the body's vascular system as a bustling, complex city grid.
The immune complexes are heavy bags of trash generated by the city's inhabitants. Normally, you have a highly efficient, constant fleet of garbage trucks. These are the C2 and C4 complement proteins that constantly patrol the streets, picking up the trash, keeping the traffic moving, and clearing it away to the dump.
But in a Type 3 hypersensitivity, something alters the math.
Maybe there is a chronic, lingering bacterial infection like endocarditis. Or perhaps an autoimmune disease, like systemic lupus, where the body is constantly producing antibodies against its own circulating DNA. Suddenly, the production of antigens skyrockets into the billions. The production of trash becomes astronomical.
And the fleet of C2 and C4 garbage trucks can't keep up. They are completely overwhelmed.
Production massively, overwhelmingly exceeds clearance capacity. Without enough C2 and C4 to act as escorts and keep them soluble, these massive, heavy trash bags, the immune complexes, begin to physically precipitate. They literally fall out of the fluid solution due to their sheer molecular weight.
If they aren't floating, where do they go?
They fall to the bottom of the vessel. They begin to deposit and glue themselves onto the endothelial lining of the blood vessels. And they don't just deposit anywhere, they specifically pile up and block the narrowest, most high-pressure alleyways in the city. Anatomically, this means the microvasculature, the tiny filtering capillaries of the kidneys, the delicate synovial vessels in your joints, and the microvessels in your skin.
So now we have millions of microscopic garbage bags physically glued to the walls of the blood vessels in the kidneys and joints. This structural blockage initiates the inflammatory cascade. What happens next?
Once these Y-shaped IgG antibodies are densely deposited on the endothelium, their Fc tails are packed tightly together. This massive concentration hyperactivates the complement system right there on the vessel wall. The complement waterfall activates, but because the complexes are stuck, the collateral damage is localized to the vessel tissue. During this intense complement activation, several small, highly reactive complement fragments are cleaved off and released into the surrounding tissue, specifically fragments named C3a, C4a, and C5a.
In immunology, those three are notorious. They have a specific name, anaphylatoxins.
Yes, C3a, C4a, and C5a are incredibly potent signaling molecules. First, they can directly interact with nearby mast cells in the tissue, triggering them to degranulate.
Wait, mast cells degranulating. We learned in Type I that mast cells only degranulate when IgE is cross-linked.
This is a critical mechanistic overlap. This is another way mast cells can be activated completely independent of IgE. C3a, C4a, and C5a can bind directly to specialized receptors on the mast cell, forcing it to dump its histamine. The local histamine increases blood vessel permeability, creating space for the next wave of the attack.
So the vessels open up. What is coming through?
The real damage comes from C5a. C5a is a tremendously powerful chemotactic factor. It is a chemical siren that specifically recruits massive numbers of neutrophils from the central bloodstream, pulling them out of circulation and directly into the vessel wall where the complexes are deposited.
Neutrophils are the immune system's heavy infantry. They are first responders packed with toxic chemicals.
And they arrive essentially blind with rage. The neutrophils swarm the area guided by the C5a gradient. They see the immune complexes stuck to the endothelial wall, and their prime directive is to eat them via phagocytosis. But they can't. The complexes are physically glued to the basement membrane of the blood vessel itself.
The neutrophil can't swallow the wall. It's like trying to eat a stain out of a carpet.
Exactly. The neutrophil attempts to engulf the complex, fails, and in its biochemical frustration, it undergoes what we term frustrated phagocytosis. The neutrophil essentially vomits its internal destructive enzymes, its highly acidic lysosomes, and tissue-destroying free radicals directly outward onto the blood vessel wall.
It just blankets the area in toxic chemicals.
This massive friendly fire completely destroys the local endothelial cells. It chews through the vessel wall, leading to severe localized tissue necrosis, microhemorrhages, and profound inflammation of the blood vessels, a clinical condition we call vasculitis.
That is brutal. The overwhelming pile of garbage bags attracts the army, and the army literally burns down the city streets to get rid of them. Let's do our clinical anchoring to see what this abstract vascular destruction looks like in an actual patient. Let's start with a localized version, the Arthus reaction.
A purely localized type 3 reaction is called the Arthus reaction. You often see this in a clinical setting shortly after a patient receives a booster vaccination, like a tetanus shot.
How does a vaccine trigger this?
Imagine a patient who already has a very high level of circulating IgG antibodies against the tetanus antigen from previous shots. When you inject a high concentration of that same antigen locally into the muscle of their arm, massive immune complexes form instantly, right there in that localized tissue space. The clearance mechanisms are locally overwhelmed, the complement cascade activates, C5a is produced, neutrophils rush into the injection site, and they spew their enzymes. Within 4 to 12 hours, the injection site becomes fiercely red, intensely swollen, highly painful, and in severe cases, the tissue in the center can actually undergo localized necrosis.
That perfectly explains the incredibly sore, swollen arm some people get after a booster. But what if the antigen isn't just injected into an arm? What if it's circulating everywhere? Let's explore the classic systemic version, serum sickness.
Serum sickness is the quintessential systemic type 3 hypersensitivity. To understand it, you have to look at the fascinating historical context. Before the mass production of antibiotics in the mid-20th century, doctors had very few weapons against devastating bacterial infections like diphtheria or pneumococcal pneumonia. They relied on a technique called serum therapy.
How did serum therapy work?
Doctors would take the live, lethal bacteria and inject them into a large animal, typically a horse. The horse's immune system would fight off the infection and produce massive amounts of horse-derived antibodies against the bacteria. The doctors would then bleed the horse, purify the blood serum containing those horse antibodies, and inject large volumes of that horse serum directly into the sick human patient.
Well, horse antibodies would circulate in the human, hunt down the bacteria, and cure the pneumonia, which is brilliant, but it created an entirely new, massive immunological problem.
Right, because to the human immune system, those life-saving horse antibodies are just massive amounts of foreign, highly soluble animal proteins floating in the blood.
The immune system realizes the human is full of horse protein. But the reaction to this doesn't happen immediately, does it?
No, and the timeline is the most critical diagnostic clue. Mechanistically, there is a distinct, predictable 7 to 10 day delay before the patient gets sick again.
Why the delay? Why doesn't the complement system attack immediately?
Because the human patient doesn't have any antibodies against horse proteins yet. It takes exactly 7 to 10 days for the human's APCs to process the horse protein, travel to the lymph node, present it to T cells, activate the B cells for those B cells to undergo massive clonal expansion, and to finally synthesize enough of their own human IgG antibodies against the horse antigens.
So for a week, the horse proteins are just floating around harmlessly.
But on day 8 or 9, the human IgG factories come online. Millions of human IgG antibodies flood the systemic circulation. They immediately meet the billions of circulating horse proteins, and massive soluble immune complexes form everywhere all at once.
The garbage trucks are instantaneously systemically overwhelmed across the entire body.
Completely. The complexes precipitate out of the blood and deposit in the microvasculature simultaneously across multiple organ systems. They deposit in the filtering glomeruli of the kidneys, causing severe nephritis and kidney failure. They deposit in the delicate synovial tissue of the joints, causing excruciating arthritis. And they deposit in the capillary buds of the skin, causing a systemic, spreading vasculitic rash, accompanied by a raging systemic fever as the neutrophils destroy the vessel walls.
That is serum sickness. You survive the pneumonia only to have your own immune system tear apart your blood vessels a week later. Do we still see this today, since we aren't using horse serum?
We use much purer, bioengineered, humanized antibodies today, but we still frequently see serum sickness-like reactions to certain high-dose drugs like high-dose intravenous penicillins or certain monoclonal antibody therapies. The mechanism remains exactly the same: a massive influx of a soluble antigen, a 7 to 10-day delay for IgG production, overwhelming immune complex formation, and systemic neutrophil-driven vasculitis.
It's a sobering reminder of the sheer destructive power of the complement system and neutrophils when they are misdirected. Okay, a quick synthesis of Module 4. We saw how soluble immune complexes overwhelm C2 and C4 clearance, deposit in vessels, and trigger C3a, C4a, C5a in neutrophils. Now, as we prepare for our final module, take a step back and look at the weaponry we've discussed so far. Type I used IgE. Type 2 used IgG and IgM attacking cells. Type 3 used IgG forming floating clumps. All three of these pathways are fundamentally driven by antibodies.
Yes, those are all classifications of humoral immunity. The B cells and their antibody products are the primary instigators.
But the immune system has another branch entirely. Module 5. Type ID hypersensitivity throws the antibody playbook out the window.
It is a massive paradigm shift. Type 4, also known as delayed or cell-mediated hypersensitivity, is entirely orchestrated by T cells. There are absolutely no antibodies, no IgE, no IgG, no B cells driving the core mechanism of this reaction.
And because it uses a different branch of the military, it operates on a completely different time frame.
Hence the name delayed. While Type I can kill a patient in 3 minutes, and Types 2 and 3 rely on relatively quick complement cascades once the antibodies are present, Type 4 takes a painstakingly slow 24 to 72 hours to clinically manifest.
Let's break down that cellular march. Why does it take 3 days for a rash to appear?
Because the cells physically have to walk the distance. The cascade begins when an antigen enters the local tissue, say, the skin. A local antigen-presenting cell, like a dendritic cell or a macrophage, ingests it. Just like in Type 1, it processes the antigen and presents a peptide fragment on its surface. However, it specifically utilizes a specialized docking cradle called an MHC class II molecule.
Major histocompatibility complex 2.
Right. The APC then physically crawls out of the tissue, enters the lymphatic vessels, and travels to a local lymph node. There, it presents this MHC2I peptide complex to a memory T cell. But crucially this time, it presents it to a memory Th1 cell. Notice this is Th1, not the Th2 cell we saw triggering allergies in Type 1.
The Th1 cell is a completely different general. It has a different strategic battle plan.
Exactly. When the Th1 cell's receptor perfectly matches the antigen, it becomes highly activated. But it doesn't send chemical signals to B cells to make antibodies. Instead, the Th1 cell undergoes rapid cellular division, enters the bloodstream, and physically travels all the way back to the exact site of the original antigen exposure in the tissue.
The general leaves the command center and goes directly to the front line.
Once it arrives back in the local tissue, the Th1 cell assesses the situation and releases a fierce, highly specific inflammatory cytokine cocktail into the surrounding area.
Let's detail that specific Th1 cocktail because the chemicals dictate the destruction. What is the Th1 cell secreting?
The primary weapons are IFN gamma, meaning interferon gamma, TNF alpha, which is tumor necrosis factor alpha, IL-8, IL-3, and GM-CSF.
What does that specific chemical profile actually accomplish in the tissue?
It acts as a blazing, inescapable beacon for macrophages. IFN gamma is arguably the most potent activator of macrophages known in biology. When resting macrophages are hit with IFN gamma, they transform into hyperaggressive, highly phagocytic killers. IL-8 acts as a chemokine to physically draw them into the area.
And what about IL-3 and GM-CSF?
Those two cytokines travel through the blood to the bone marrow, specifically stimulating the marrow to aggressively overproduce monocytes. Those monocytes enter the blood, travel to the tissue, and mature into even more macrophages.
So the Th1 cell is basically dropping a chemical pin on the map and summoning an ever-growing, enraged army of macrophages directly to that localized millimeter of tissue.
Yes. And it simply takes time, 24 to 72 hours, for the APC to crawl to the lymph node, the Th1 to activate and travel back, secrete the cytokines, for the bone marrow to respond, and for the massive army of macrophages to physically infiltrate the tissue.
When they finally arrive in those massive numbers, what does it physically look like?
They cause intense, highly visible, physically hardened inflammation. The macrophages release lytic enzymes and cause local tissue destruction, but because they are packed so tightly together, the tissue actually becomes indurated, or hard to the touch. In chronic cases, if the macrophages can't destroy the antigen, they will actually fuse their cell membranes together to form massive, multinucleated giant cells, attempting to physically wall off the area in a structure called a granuloma.
Let's apply this delayed mechanism to the real world. Clinical anchoring. How do doctors use this 72-hour cellular march practically? Let's talk about the tuberculin test, better known as the MAN2 test.
This is a brilliant diagnostic test that purely leverages type 5e hypersensitivity. Doctors use it to determine if a patient has ever been infected with Mycobacterium tuberculosis, the bacteria that causes TB.
How does the test actually work mechanically?
We take a tiny standardized amount of purified protein derivative, or PPD, which is an extract of the tuberculosis bacteria. It is not the live bacteria, cannot cause an infection. It is just a dead protein fragment. We inject this protein intradermally, just under the very top layer of the skin on the patient's forearm.
If the person has never been exposed to TB in their life, their immune system just clears the dead protein and nothing happens.
Exactly. But if that patient has been exposed in the past, or if they were vaccinated with the BCG vaccine, they will possess long-lived memory Th1 cells specific to that exact TB protein, constantly patrolling their body.
So over the next few days, the cascade begins.
Local APCs at the injection site pick up the injected TB protein and present it. The patrolling memory Th1 cells recognize it, rush into the injection site in the arm, release huge amounts of IFN gamma, and summon the macrophage army.
And that is why the doctor doesn't look at your arm on the same day. You have to come back to the clinic 2 to 3 days later.
Yeah.
What exactly is the doctor looking for?
48 to 72 hours later, the doctor isn't just looking for a red mark like a histamine flare. They literally take their fingers and press on your arm, feeling for a measurable, hardened, raised bump, an induration.
Why is it physically hard?
It is hard because that specific millimeter of skin is now densely, physically packed with thousands of infiltrating Th1 cells and massive, angry macrophages that have completely saturated the tissue architecture. The larger the diameter of that hardened cellular army, the stronger the immune memory, indicating a likely TB infection.
That's fascinating. They aren't feeling swelling, they are literally feeling the physical density of the immune cells that migrated there. Now, there's another incredibly common manifestation of type 5e hypersensitivity that affects millions of people. Allergic contact dermatitis, people getting terrible blistering rashes from cheap jewelry or walking through a patch of poison ivy.
Contact dermatitis brings us to the fascinating biochemical concept of haptens. Haptens are very specific, tiny inorganic molecules or simple plant oils. The classic examples are the metal nickel, which is often mixed into cheap coins, belt buckles, and necklaces, or urushiol, which is the highly reactive oil found on the leaves of poison ivy and poison oak.
Here's the paradox, though. Nickel is an element. It's tiny. We just established that the immune system looks for complex protein peptide chains, like strawberry proteins or TB fragments. How can a single microscopic atom of nickel trigger a massive macrophage army?
On its own, it absolutely cannot. To understand how haptens bypass the system, think of a tiny disguise kit.
Okay, a microscopic disguise kit.
Nickel, the haptens, is structurally so small that it is completely invisible to the immune system's radar. The APC security guards walk right past it. It cannot trigger an immune response alone. But when you wear a cheap nickel necklace on a hot day, your sweat slightly dissolves the metal. Microscopic nickel ions penetrate the very outer layer of your epidermis.
And once inside the skin, it opens the disguise kit.
It acts as an incredibly reactive chemical binder. The nickel rapidly attaches itself to normal, harmless host proteins that naturally exist in your skin cells.
It slaps a fake mustache and glasses onto a completely innocent local citizen.
Exactly. By chemically binding to your own host skin protein, the nickel physically alters the three-dimensional appearance of that protein just enough that the immune system no longer recognizes it as self. The local APCs walk by, see this newly modified protein, and suddenly view this local citizen as a foreign, dangerous spy.
It flags the modified protein as highly dangerous, picks it up, travels to the lymph node, and launches the Th1 cascade.
The Th1 cells deploy, travel back to the neck where the necklace is resting, secrete IFN gamma, and the macrophage army arrives.
And 48 hours after putting on the cheap necklace, your neck breaks out in a red, raised, blistering, incredibly itchy rash, contact dermatitis.
The profound tragedy of this is that the immune system is destroying its own perfectly healthy skin cells simply because they were forced to wear a nickel disguise. It is an incredible demonstration of just how hypersensitive and unforgiving our T-cell surveillance really is. If the protein structure is altered even slightly, the T-cells authorize total localized destruction.
Wow. We have covered a truly massive, intricate amount of immunological ground today. We've traced the blistering speed of immediate IgE cross-linking, dropping blood pressure in minutes. We've watched IgG paint a bullseye on fetal red blood cells, leading to tragic cellular destruction. We've mapped how overwhelmed garbage trucks lead to immune complex pileups and systemic vasculitis. And we've just tracked the painstaking 72-hour march of T cells and macrophages assassinating disguised skin cells.
If we connect this to the bigger picture, I'd like to leave you with a thought regarding the environmental shift we discussed earlier. Consider the hygiene hypothesis and the modern lack of regulatory T cells.
The peacekeepers.
Exactly. As we continue to relentlessly sanitize our modern environments, as we live in hermetically sealed, air-conditioned homes, and as we fundamentally reshape our internal gut microbiomes with heavily processed foods, chemical preservatives, and broad-spectrum antibiotics, are we essentially guaranteeing an escalating epidemic of hypersensitivity for all future generations?
We are rewriting the rules of engagement that our bodies evolved to follow.
Our immune systems evolved over millions of years to fight in a profoundly dirty, microbe-rich world. If we completely remove the dirt, the massively powerful weaponry of the immune system doesn't just turn off. It idles, it misfires, and eventually it turns on us. The great immunological challenge of the 21st century isn't just inventing new drugs to block these pathways. It is answering a much deeper question. Can we find a way to retrain the immune system's peacekeepers, the tregs, and restore the balance without forcing humanity to return to a world plagued by dangerous, unchecked infectious diseases?
It's a profound, almost philosophical question to chew on. Is our pursuit of absolute cleanliness actually making us fundamentally, structurally allergic to our own environment? I want to thank you, the listener, for taking this incredibly dense, highly rewarding masterclass deep dive with us today. Remember, true biomedical knowledge doesn't come from just memorizing the final list of symptoms. It comes from deeply understanding the exact cellular mechanisms churning beneath them. When you understand that the diagnostic X-ray is broken, you can finally start looking at the muddy waters of the immune system with clarity. Keep exploring the microscopic world, keep questioning the mechanics, and we'll see you on the next deep dive.